Today we're going to talk about the serious illness conversations in acute medicine and surgery. My name's Ruth McRedmond. I'm an ICU physician here at Providence, and joining me today will be Dr. Rose Hatala from Palliative Care and Wallace Robinson, who's our Providence leader for advanced care planning. We hope through the course of the video we're going to talk about some of the rationale for the serious illness conversation and why we should be using it ahead of filling out a DNAR or a MOST form, give you a little bit of background around the research and development of the guide, and then provide a demonstration to show how you can maybe incorporate this into your own practice. We have no disclosures or conflict of interest to report, and this slide just acknowledges the content on which a lot of this workshop is based. So the foundation for advanced care planning is developing an understanding between us as clinicians and our patients. Our patients need to understand their health status, their medical condition, and their overall prognosis. We as clinicians need to understand what's important to patients, particularly as they're nearing the end of their lives. This sounds like it's fairly straightforward, but in fact, the literature shows us that there's a huge gap in advanced care planning. Even in the oncology population, where we know prognosis can be fairly well estimated, many patients do not engage in any kind of end-of-life conversations with their clinicians until very shortly before their death. This is even less likely to happen in patients with chronic comorbidities. The conversations that are had often fail to address the key elements, so they tend to focus very much on resuscitation status rather than focusing on what's important to patients and what their goals and fears are. This gap in advanced care planning results in poor quality end-of-life care. As clinicians, our training and our focus tends to be on cure and on prolonging life. Studies tell us that patients' priorities at end of life are in fact quite different. They're focused very much on symptom control, on maintaining their functional status, and also on having the opportunity to achieve closure in their relationships or to relieve the burdens on their families. And unless we have elicited those wishes from them, they often don't receive the support they need to achieve that. The way we generally record advanced care planning is with a DNAR or a MOST form, but many studies show us that that is in fact inadequate. A couple of really good studies that were performed in Canada show there's a real disconnect between what's often recorded in a MOST form and what it is that patients actually want. And that's largely because we're not really having the conversations with our patients prior to filling out these forms. And as a result, patients often have inappropriate interventions at end of life that don't really benefit them. Here at Providence, we have had a big push to complete DNAR forms on every patient who's admitted to the hospital. But when we review our data here, looking at 100 consecutive deaths in the hospital for areas where their care may have been better, what we found is that end-of-life opportunities for improvement are the most frequent opportunities that we see. Over a quarter of our patients have areas of their end of life where their care could have been better. And most frequently, this is because there was lack of clarity around what their goals of care were. This filters then down into inappropriate interventions and also failure to engage our palliative care colleagues when the patient may have benefited from such care. This gap is not at all confined to St. Paul's. When we look at a survey across BC, we see that over a quarter of deaths in BC are deemed to be palliative, but less than half of these patients have ever been referred to palliative care or indeed received palliative care benefits. So by not understanding what our patients want, we're certainly missing an opportunity to give them better end-of-life care. One of the reasons these conversations don't happen is that we as clinicians are worried that we're going to frighten patients, that they're going to be surprised by them, that they are going to feel that their hope is being taken away. In fact, when we poll patients and the public, we find that most people have actually thought about advanced care planning at some time. Over 3/4 of patients have thought about who should make decisions for them if they became unwell, or have thought about what's important to them if their health status was to decline. Less than 10% of people, however, have actually spoken to their doctors about it. The fact is that patients are not going to initiate these conversations themselves. It's up to us as clinicians to do it. And part of the reason to engage in training such as this is to empower physicians to initiate and to complete these conversations and for them to be good, high quality conversations. So why do we use a guide or a checklist? Many people feel that communication skills are inherent, but in fact, like many other procedures in healthcare, communication can be learned and with practice can improve. We use checklists for all kinds of things in healthcare. We know that they improve the general level of baseline performance and it avoids errors. It means that we complete the necessary tasks, particularly in very stressful situations. And conversations about advanced care planning or end of life certainly can be stressful and they can be emotional. And having a checklist to refer to can help us ensure that we hit all of the key elements to the conversation. Studies show that using a guide such as ours can reduce clinician anxiety, allow us to be more focused on the conversation as well. If I know what the next step to the conversation is going to be, it's easier for me to actually stop and listen and really take in what the patient is saying.
In the rest of this workshop, we're going to focus on the specific serious illness conversation guide that was created by Atul Gawande and his colleagues at Ariadne Labs. I think the advantage of this particular checklist is that it actually includes language that's been tested both with patients and with providers that have been having these conversations for some time. And that kind of patient and provider tested language is quite helpful to us when we're first learning how to do this conversation. One of the things I'm going to recommend as we walk through this specific conversation is that if you're trying this for one of the first times, I really encourage you to have the guide open in front of you. And actually, it's okay to look down at that language, to try using that language. And then over time, given all your experience, you will nuance which bits of the conversation work for you and what language you'd like to keep. So as we go through this, you may even want to open a copy of the Serious Illness Conversation Guide to follow along. There are really a number of key elements to the conversation. The first is that we elicit the patient's understanding of their illness, and then we share prognosis. Following that, there's a number of concepts that we're going to elicit from the patient, including their goals, their fears, their sources of strength, what they feel their critical abilities are, what they are willing to trade off, and how much their family knows about this. And then absolutely key to the entire conversation is that at the end of this, if we've truly listened to the patient and heard what's most important to them from their life journey, their values, then we can actually make a recommendation that's in line both with what we understand about the medical evidence, but also what the patient has told us about what's important to them. So let's dive into the conversation. The first part that's very important is actually to have permission to have the conversation, to set it up with the patient. I'd like to talk with you about what may be ahead with your illness so that we can better prepare for how to best take care of you. And to set time aside that you're having this conversation not in a rushed fashion, to see if the patient wants to have any family or friends present to support them as they go through the conversation. And taking this time to set it up and to signpost that we're having the conversation helps to build trust and engagement. We then want to understand what the patient knows about their illness because that helps us understand the context for the conversation. And so language in the guide includes statements such as, what is your understanding now of where you are with your illness? And also asks the patient, how much information about what might be ahead might you like from me? Once the patient has stated or shared what they understand of their illness, then it's our turn to actually share our understanding of prognosis. And we might convey this both in terms of our uncertainty around the patient's prognosis or some sense of time or change in functional status that might occur as the patient's illness goes forwards. One of the most important aspects at this moment in the conversation is that we're not here to take away hope from the patient for their hope for what their future may bring or how their illness may go, but to try and get both of us in more of a shared space about what might be the reality of what may happen with their illness. And one really useful phrase for doing this is the wish, worry, wonder phrase. So that whatever the patient states about their understanding of their prognosis, particularly if it is quite optimistic compared to our understanding, is to say that I wish too that this would be your outcome, but I'm very worried that things may be different, and I wonder if we could have a conversation about this other possibility. And by saying I wish, you're aligning yourself with the patient's hope, But with the worry and the wonder, we're bringing ourselves back to what may be the more realistic outcome for the patient. At this moment in the conversation, and having shared prognosis, particularly if you and the patient were in very different places as you started the conversation, you need to expect emotion. This will be very upsetting for the patient, and we need to take time in the conversation to acknowledge that emotion and to have that conversation about the emotion, which in itself can be quite therapeutic. We can name that emotion and respond to it. And just take the time to acknowledge how difficult it is, what we're sharing and what we're considering here for the patient's future. After spending that time, then we can move through exploring the key topics. The first one is actually asking the patient what their most important goals would be as they think ahead to their future with their illness. And then following that up with what are their fears or worries about what may be ahead. The next question explores what are their sources of strength as they think about their future with their illness. And here they may reply things around their family or friends, spiritual, religious, these sorts of domains. The conversation then moves to asking the patient what abilities are so critical to their life that they can't imagine life without them. And here they might tell you things such as their cognition or their mobility, things in those realms. The next question then asks for trade-offs. If you could become sicker, how much are you willing to go through for the sake of more time? And I find that question in the conversation, what's very helpful for me is if I have a specific trade-off that I'm considering in my mind, to ask the patient those specifics. Are you willing to go through X for the sake of more time? So that you can both get a feel for how that specific decision might unfold. The last point here in the conversation then is to explore whether the patient's family or supports know about the current illness and what the future may hold, whether the patient would like you to involve them in future conversations. The patient has some support as they consider these decisions. And as I mentioned previously, if we've truly listened through this element of the conversation, through those threads of their goals and their worries, then we will have a pretty rich understanding of what's important to the patient, what they're worried about, what they may be willing to trade off. And so we can close the conversation by actually making a recommendation, by saying, I've heard you say whatever is important, and keeping that in mind, knowing what I know about the medical side of things, this is my recommendation for going forward. And then checking in with the patient. How does that plan seem to you? Having a bit of discussion around that. And then we can close out the conversation by affirming our commitment that we're going to continue to care for the patient throughout the course of their illness. After concluding the conversation, it's really important that we then document that conversation so that other healthcare providers are aware of the patient's values and preferences and what the recommendation and plan is going forward. Here at Providence, in Cerner, you can document the conversation either in a free text note in the documentation section, title it Goals of Care, or there is actually a power form entitled Goals of Care, which you could use. Ensure that the code status matches with the outcome of that conversation, if that's an element that you've discussed, and then make sure that key colleagues caring for the patient are also aware of the outcome of the conversation and are also aware of the documentation. We're now going to move into a role play between myself as the physician and my colleague Wallace as the patient to demonstrate some elements of this conversation. And so in this demonstration, I'm an internal medicine physician, and our patient Wallace is a 70-year-old man with significant medical problems, including type 2 diabetes, ischemic heart disease, and peripheral vascular disease. And overall, he's somewhat nearing his end of life in the big picture. Now he's admitted to hospital under internal medicine with a diabetic left foot infection. Vascular surgery has consulted and potentially recommended revascularization of his left leg. And myself as the physician, I'm going to have a conversation with Wallace about this decision with respect to his care. Hey, Wallace.
Hey, Dr. Hadala.
How are you doing?
You know, I'm hanging in here. I'm ready to go home, though.
You've only been here 2 days.
No, but I'm still ready to go home.
I was wondering if we could take a little bit of time today to talk about what's happening with your current illness and what some of the options might be. It'll help me understand and plan a little bit for the future.
Yeah, for sure. Yeah.
Okay, that sounds good. Do you mind sharing with me what you understand about why you're in hospital? And then I know you also met with a surgeon yesterday, if you can kind of catch me up on that as well.
Yeah, it's this toe is really infected. It hasn't healed up. And so, yeah, think I'm on antibiotics for that now, right?
Yes.
And, so the surgeon said that he thought they could fix it. They could do surgery to maybe fix it, restore the circulation, help it heal up, but that there were risks. I mean, I even heard him say there was a risk of death and complications like heart or heart attack or a stroke, which is like, God, even worse than dying to me. Yeah. So it's my diabetes getting worse.
Yeah. Would it be okay if I shared with you a little bit my understanding of where things are at?
Oh, yeah. I trust you. I want to hear where we are and where we might be going.
Yeah, I mean, I think I understand things pretty similarly to you, that you have this infection in your foot, we've got you on antibiotics, and part of the problem is that blood flow, and that surgery is an option, and that might help that toe heal. But for someone like you, with your heart disease and the diabetes, that surgery does come with a risk. And if I had to put a number on that risk, it's not a precise science, but I might say it's 5 to 10% chance that you could have a heart attack or a stroke or even die by going through that type of vascular surgery. The alternative would be to just keep doing what we're doing with the antibiotics and know that there's a possibility down the road that you might need to have that toe amputated or part of your foot amputated, but that those surgeries aren't quite as risky as the vascular type surgery. How does that sit with you?
I don't know. It's kind of a tough choice. The surgery sounds a little bit like when I had the heart surgery, and it took a long time to recover from that. And although I'm glad I did it, I said I'd never do it again. I don't know, it's tough.
Let me ask you a few questions that might help us with some of that decision making. When you think ahead of life with your illness, what's most important to you?
Well, I mean, to be honest, I know, I'm 70 and I've had diabetes for a long time and I'm starting to get these complications, and I know I'm getting near the end of my life. And I want to spend time with my partner at home and gardening like we do. And even though I don't do much of it now, I'm the boss mostly. We spend time home as a family with our dogs, and I really value that.
Yeah.
I miss that when I'm in here.
I bet. The garden this time of year is probably looking pretty beautiful. Yeah. What are you most afraid of thinking of the future and your health?
I mean, I think my biggest fear is getting stuck in hospital for no good reason toward the end of my life, and maybe and just suffering for no good reason, and all of that being a burden on my partner. I don't want that to happen.
You mentioned you have faced some tough decisions and some health scares in the past. Where are your sources of strength?
I don't know, where do we get strength from? I mean, I think I've gotten it from facing challenges over time, and I pray, I don't know to what or to whom, but it's just hard to imagine that we're completely alone. And I don't know, I just have strength from my life as it is.
Yeah, I see you as pretty resilient, that's for sure.
Some days.
Yeah. Thinking about the future, what abilities to you are so critical that you can't imagine life without them?
I think I have to be mobile. Like, I can't imagine being bedridden. That would be time. Or not having my cognitive abilities, my brain, and knowing where I am, being confused, like that's not okay either.
And so when you think about these various treatment options, is there any that feel you'd be willing to go through for the sake of more time?
I don't know. I think I don't want to spend a lot of time in here. And no, I really don't. And I worry that the vascular surgery might end up that way, or even worse, like with a complication. I mean, I don't think that's really a risk that I want to take. I'm okay with like a bad toe. It doesn't hurt. And if I have to have it chopped off sometime, that seems simple enough. I'm willing to do that, but I'm really doubting that I'm willing to go through something that complicated. It sounds complicated.
Mm. It's a big decision. Have you talked to your partner about the things that you're facing right now?
Not really. I haven't talked to him about really in detail about what the surgeon said, and kind of you talking to me now is helping clarify things a bit for me. I think we need to have a good talk. Maybe later today or tonight. I think I have to make a decision pretty soon.
Yeah, I think it would be important to include him, and if you want me to help with that conversation, I'm also happy to do that. If I listen to everything that you've told me, I can hear pretty clearly that sort of what's most important to you is to maintain your quality of life with time at home, time with your partner, time as yourself in the garden, those sorts of things. And that you're really afraid of prolonged hospital time, of being bedbound, of suffering. And weighing those things together, my recommendation would be that we don't proceed with the vascular surgery right now. Continue on with our current treatments with antibiotics, and recognizing that we may face the need for an amputation of some sort down the road. How does that plan sound to you?
Almost relieving. I mean, I think that summarizes what I was thinking and trying to say, but couldn't really say.
Yeah. And this is an ongoing conversation, Wallace, and I'm going to continue to take care of you both here and when you leave the hospital. So we'll just continue to have these conversations as we go forward. Sound good?
Sure.
Okay, I'll check in with you tomorrow.
Okay, cool. Yeah, I'll look forward to seeing you then, and I'll have a talk with my partner in the meantime, right?
Okay, cool. Thanks.
When patients are surveyed about what's most important to them in their communication with their physicians and other healthcare providers, they most often say that respect and compassion are the things that they value the most. So these things are important: honesty, allowing silence, eliciting the patient's goals, fears, and what's most important to them, and really listening, as Rose has just demonstrated in that demonstration. We should resist the urge to give premature reassurance, and also resist the tendency to focus on medical procedures and facts when the patient is expressing emotion. As healthcare providers, we have other priorities on our minds, so it can be challenging to slow down and listen and acknowledge that there is a human need to be seen and known, and that's especially true when patients are vulnerable in difficult health situations or as they near end of life. So we hope that the approach and the tips demonstrated in this video add to your confidence in engaging in these conversations with your patients. There are a few resources outlined here, which will also be embedded in the description below the video that you can click on. They will lead you to a short video of Atul Gawande summarizing what is important in these conversations. There's also an annotated demonstration of a conversation by Dr. Susan Block, one of the authors of this approach. And there are also resources, translated resources available on the VCH Intranet that will be available to you below in the description. And also, if you have any questions or would like additional resources, please feel free to email me and I will respond. So thank you so very much.